Good afternoon, everybody. My name is Vijay Ravindra. As Dr. Grant mentioned, I am currently at the Naval Medical Center San Diego, and I also work at Rady Children's Hospital. And today, I'd like to talk about understanding the relationship between Chiari malformation and scoliosis. Here are my disclosures, none of which are relevant to this topic. So a brief outline of what we're going to cover today. The first thing is we're going to define the relationship. Chiari and scoliosis are often mentioned as in the same breath, but whether the association is well understood or not is kind of a different story. We'll talk about a little bit of epidemiology, which is important to really understand how common this problem is. And then we'll get to some practical matters. Okay, so I have a Chiari malformation and I have scoliosis. What does that mean? Well, what are the implications? What now? We'll talk about some of the long-term implications of Chiari and scoliosis. And as with these types of things, I always like to look at a case example because it helps me really think about things, from a management standpoint to a practical standpoint. And then we'll take any questions that you guys might have. So, a few points, themes to consider that you're going to hear throughout the majority of this talk is that Chiari malformation type 1 and syringomyelia and scoliosis can occur in combination. The diagnostic workup for this requires a very careful attention to the history, physical examination, and imaging findings. When you have a Chiari and you have scoliosis, depending on when the presentation is and when diagnosis happens, is surgery for the Chiari malformation may actually improve or at least stabilize the curve or the scoliosis. And lastly, that deformity correction or scoliosis surgery can be performed in the setting of Chiari malformation, syringomyelia, and the risk of neurological deficit is low, but it's not zero. So some definitions, as you've heard over the past several days, we have these standardized definitions of Chiari malformation, and Chiari 1 is just defined as descent of the cerebellar tonsils about 5 millimeters below the foramen magnum. The most common presentation is headache, but an uncommon presentation, but can occur, is really presenting with an abnormal curvature of the spine or scoliosis. Nearly 20% of Chiari malformation patients have scoliosis. And when you look at Chiari malformation patients that have a syrinx, nearly 30 to 70% have scoliosis. So with syringomyelia, the risk and the prevalence goes up quite a bit.
So the pathophysiology, as you've probably heard a few times in this, it's not well understood. It's thought to involve some of the anterior horn cells or some of the really fine neurons in the spinal cord. We also think there's another theory that some of the medial nuclei cells of the spinal cord get damaged when there's a syrinx that enlarges over time, and that causes loss of neural function to the trunk musculature, which promotes that scoliosis curve. It's really important that we understand that there's limited high-level evidence on this topic, and so what we have is not only our experience, but kind of small, often single-center, some multi-center studies. So here's a case example from my clinic. This is a 13-year-old male who had a history of some right hand weakness. He's a pretty high-functional kid. Parents didn't notice it until his handwriting started to suffer. He complained of a lot of back pain, though. He would play soccer or football and complain that his back would hurt. Upon further probing, this was not volunteered, believe me, he had headaches, and they tended to be worse when he was playing or active or when he coughed. No difficulty swallowing, no history of any sleep apnea. So on his examination in my clinic, this is pulled straight from my clinic note, he was actually pretty neurologically intact on my examination, with the exception that his right hand was really weak. And when I would have him flex his head down, he would have this lightning sensation that would go through his arms and his shoulders. His reflexes were all normal. He was walking totally fine. So this is the MRI that they obtained at an outside center, and he came with. And a lot of you, may have MRIs that look similar to this, or seen a bunch of MRIs that look similar to this. This is read as a Chiari-1 malformation with 7 millimeters of tonsillar descent. Now, if you look at the right-hand image here, that's a sagittal, or kind of a side-cut MRI scan, and you kind of see there's that black absence there. And so that tells me that it's a bit out of plane. So when I see this, I don't need an x-ray. This patient has scoliosis. Their spine is curving in a way that it's not supposed to, and it's causing the plane of the image to be off. And lo and behold, we get a set of x-rays. On the left, we have a anterior-posterior image, and you can see that there's curvature of the spine through the middle part of the spine, the thoracic spine. And on the right-hand side, we see a standing x-ray, and, it doesn't look too bad at first glance, but when you really look at it, you see that there's exaggeration of the curvature of the middle part of the back, almost like a humpback, okay? And this is hyperkyphosis. So we, I obviously counseled the family and the child on this, and I said, you have scoliosis and you have a Chiari malformation. I thought the Chiari malformation was clinically symptomatic based on the headaches, based on the arm and hand weakness. So we did a suboccipital decompression and duroplasty and had a marked improvement of the syrinx. Really impressive. And this was his 3-month MRI scan. It was read as 50% resolution of the syrinx. And I'll tell you, I thought this kid was going to be happy as a clam, but his back was killing him. He said, my back is just horrible. And so I said, okay, let's get you into some physical therapy, try to shake out all the post-surgical cobwebs, and get him rehabbed. And this was his 9-month MRI scan. Again, stable syringomyelia, certainly no worse, if anything a little bit better, still with worsened back pain. Okay. So we get another set of x-rays. He still has his coronal scoliosis, levoscoliosis, and it's not major. It's about 30 to 40 degrees, which is not really in surgical range. But you look at that standing x-ray of the side view, and you can see that that hump in the middle part of his back has gotten worse. So based on this, he says, okay, how can you help me? So you have to think about this a little differently. It's not just a craniocervical junction problem anymore. This is a structural problem. So what we decided to do was try to correct his hyperkyphosis. We do this through a series of what's called osteotomies at the back part of the spine, where we remove both the inferior and superior articular process, take out the facet capsule, take out a little bit of the ligament. This is all outside the spinal cord. It's all extradural surgery. And this is the correction that we were able to do for him. Okay, you can see that his coronal alignment is better, but on the standing side x-ray, his kyphosis is much better. And he was taller too. So this is his 1-month postoperative films. Here he is at 1 year. Pain's completely resolved. Neurological function is stable from his post-op Chiari decompression, which was improvement in his hand function. So when you present with scoliosis, a complete neurological exam is necessary. If a kid or adult has headaches, back pain, oropharyngeal dysfunction, snoring, things like that, absence or asymmetrical abdominal reflexes, in my mind, that's a prompt that needs to be worked up for Chiari malformation. There's other red flags that we look at. So when we look at early onset scoliosis, which is really if someone's less than 10 years old, they should undergo MRI scanning, because almost a quarter of those patients can have some kind of neurological pathology that is driving the scoliosis, meaning they have a tethered cord. They have what's called a split cord malformation. They have a Chiari malformation. And in very rare instances, they might have a tumor or something that's causing the scoliosis. So you need to really look at that. When we get the older children that present with scoliosis, typically it's the young females that are of age that are getting into sports, what's called adolescent idiopathic scoliosis. The use of MRI is controversial because you'll find a Chiari about 8% of the time, which isn't that high. So, you could ask 100 practitioners and 50 will tell you one way or the other. So what is scoliosis? It's abnormal curvature of the spine with a Cobb angle of greater than 20 degrees. And this is anywhere in the spinal column. It's not limited to the thoracic or lumbar spine. A lot of scoliosis that we diagnose is asymptomatic, and it's inconsequential. So if curves are less than 20 degrees and they don't change over time, and that skeleton becomes mature after puberty, we don't worry about them because they're not going to cause problems. What we want to know is which curves are going to progress to the point that they get into the surgical range, and that's a surgical range not because we've come up with an arbitrary number, but that's where we know that physiological symptoms are going to start or can be debilitating. So when I see Chiari-related scoliosis, there's certain things that I think about. So if I see a child that comes in with a left thoracic curve, a left apical curve, if it's juvenile onset, if there's neurological deficits, if there's hyperkyphosis or that exaggeration of the mid part of the back, or that curve progresses really rapidly, those are all things that send off alarms in my head and say, we need to image this kid with an MRI scan. So what if we find a syrinx and Chiari and scoliosis? What do? Well, you don't completely come apart, right? You go through your algorithms and you think about how to manage these things. So when I see this, I go back to those measurements, and I know Dr. Mayer talked about these, that everybody has a set of measurements that they use, and not one is perfect, but use them in conjunction with looking at your patient and their symptoms, and you'll be right most of the time. So I look at what's called the CXA, or the clival axial angle, the PBC2, and the CZ2 SVA to help guide my decision making, not so much for surgery versus not surgery, fusion versus not fusion, but is this Chiari for this patient a bad actor, or is this one that's not going to cause problems? Okay. And that's, I think, how I like to dichotomize things. So the guidelines for scoliosis screening with Chiari is not well defined, believe it or not. And so if a kid is diagnosed with a Chiari, what I do is I bring them to the office and I do what's called an Adams forward bending test. And that's as simple as it sounds, where you have them bend forward and you check the curvature of their spine. You look at the scapula, you look at the pelvis to see if there's any obliquity or offset. And if there is, then I get a set of x-rays. Okay. X-rays are an easy thing to do, but they're not without risk, especially when you're talking about children. So you want to be judicious with how you use your imaging. Okay. So I have scoliosis. I have a Chiari 1. Do I need to see a surgeon? And can we do surgery on both? Is it going to fix everything? Okay. So this is where we kind of uncork the bottle here a little bit. So posterior fossa decompression, it plays a major role in the treatment of Chiari patients, specifically in Chiari patients that have Syringomyelia. With scoliosis, in some patients, posterior fossa decompression actually reverses or halts the progression of scoliosis. Dr. Wong, who's a surgeon at Shriners in Philadelphia, he studied 120 patients who underwent posterior fossa decompression, and he found in 1/3 of them, the curve got better after doing a posterior fossa decompression. 20% of curves won't change and they'll stabilize. And I'll tell you, stabilization is key. If curves get better, that is just gravy. 100%, everybody's celebrating. Stabilization is what we want to see. Progression of curve is what we don't want to see. So can you put kids in a brace? Okay, they've been diagnosed with Chiari and a syrinx. Can you brace them? And scoliosis. So curves less than 20 degrees may stabilize or regress over time with bracing. Braces have to be worn up to 23 hours a day, and that's recommended. And if they're not, that's considered non-compliant. So think about if you had to wear a rigid brace, and some of you may have, for 23 hours a day. That's a tough thing to ask, especially for a child who's less than 10. We found that it's efficacious as it is in children that have adolescent idiopathic scoliosis, but it's a tough thing to swallow. What about bracing plus posterior fossa decompression? It's not well studied, but we know that the profile is similar to that of kids with adolescent idiopathic scoliosis. Okay. Do we need to open the dura? Does that make a difference for scoliosis? Well, there's been a few studies looking at this, and a 2017 meta-analysis of over close to 1,500 patients showed that duroplasty patients had greater clinical improvement, but the syrinx size and scoliosis outcomes were essentially the same. Sadler looked at 346 patients who underwent duroplasty and 51 who did not undergo duroplasty. And they found that ultimately the same number of patients required a scoliosis correction surgery, but the duroplasty group had less curve progression than the bone-only decompression group. Now, is this fantastic evidence and it guides my practice? No. But I think it's what we have so far and we need to build on it. So why does decompressing the Chiari malformation work? Well, in Chiari 1 malformation with syrinx, there's impaired flow dynamics, right? So performing posterior fossa decompression is thought to improve these flow dynamics and neurological symptoms by ultimately decreasing the velocity of the flow within the syrinx. So which patients would have the best chance of improving with this? So I'll tell you, younger patients with smaller curves, right? Like anything, you find something early and you're able to address it. Those are the patients you can help the most. So we found from 3 large studies that were fairly well done that finding Chiari malformation with Syringomyelia in the setting of scoliosis and intervening on those kids before they're 10 years of age would reverse or stabilize the curve in over 70% of the time. Okay, that's pretty good. If you told me that my child had a Chiari malformation and a syrinx and scoliosis and doing a Chiari operation would potentially save them from needing a large scoliosis surgery in their teenage years, and that rate was a 70% chance, I'd take that. That's pretty good. So that's kind of where we stand with the decision making. So I've got scoliosis and I've got a Chiari. Can I have my scoliosis corrected? Can I have my scoliosis operated on as a teenager or as an adult? Yes, you can, okay? But it's important that you understand the risks and the population, right? So we know that intraoperative and perioperative complications with scoliosis surgery are something that we take very seriously. And specifically, when we're looking at the information we use in surgery called neuromonitoring, we know that neuromonitoring changes can happen more frequently in Chiari-related scoliosis versus adolescent idiopathic scoliosis. But the number of overall complications is low, and that's because of a multitude of reasons. Number one, we choose who we operate on very carefully, and we counsel our patients very carefully. And the surgical techniques that are used, image guidance, the type of instrumentation, the way we perform surgery, that reduces the number of complications also. We also know that patients that have idiopathic syringomyelia versus Chiari-related syringomyelia, they perform about the same. So we know surgery is safe for those 2 groups of patients with relatively low complications. So that's kind of my spiel. There's some take-home points that I want you to understand. We don't know everything, okay? And I would say from this talk and some of my language, you'd say, well, you don't know anything. And that's not untrue. We're learning very quickly. There's urgent questions pending, right? So timing of surgery and age, I think, is the biggest one. If a child has Chiari malformation and they have Syringomyelia and they have scoliosis, when should I do the posterior fossa decompression? How long do you wait till after that do you do a spinal deformity correction surgery? Ultimately, we need to know about functional outcomes, right? Back pain and neck pain. A lot of patients who are doing well and don't come back, we assume that they're doing well because they don't come back, and that's not always true, right? So we need to get better about adhering to follow-up and really looking at what are called health-related quality of life outcomes, which I know you guys all know what are. There's lots to be learned about Chiari and scoliosis in general. I'd like to thank Dr. Grant, even though he made fun of my attire yesterday, Patrice, Eric, Patricia, and everybody in ASAP. This is a great conference, and I'm so happy all of you guys are here. Be happy to take any questions. I think there's a Q&A session later, so we can hold everything for now. Thanks.